So I come from the world of technology, business innovation, and so forth. So we're going to see some applications of AI in different spaces. Obviously, we are interested in healthcare, so we're going to touch on a very high level what does it mean. I really wanted to present two simple case studies now, but I'm going to proceed one in the interest of time, and we ran out of time in the last session, so I think we will. All right, this is my little outline. As you could see here, we'll give a high-level definition of AI. Most of you are aware. Then we look into machine learning, that is the subset of AI. Then we're going to also highlight some of the situations that could lend very well to machine learning. Then people also talk about different categorization of AI, so we will talk about that as well a little bit. Then I'm going to show you how you open the door hood of your car to see what is happening, right? A lot of us talk about AI and we think it's a black box, but I want to show you a little bit the inspiration that we got from human brain anatomy and the functioning of the brain itself. See how in the AI space we can leverage some of those learnings. Okay. Then we get into a little bit about the market trend, where AI is adapted, and what does the trend look like? I come from a business one, I'm a business professor here in Michigan, so that is very hard. Then we will look at some AI and mammography. I know a lot of radiologists here. I really need to have the question related to mammogram. Okay? So I just want to lay out what to expect. Alright, so when we started talking about AI, I came from Michigan. There was one physician sitting next to me, maybe 66 batch. Okay? And he was so curious, and he wanted to understand everything about AI in little less than 2 hours when I came from Michigan to Orlando. And I could see the curiosity, he still is in practice, and he's doing a lot of great stuff, but he's completely excited about the opportunity. So I just want you, I told you, wait for 24 hours, and I can give you a very high-level introduction to AI and how it's going to help healthcare. I'm sure that you've got it. Can you raise your hand if you're still in the audience? Mr. Tirumurthy, I believe, Dr. Tirumurthy. All right, okay. Where is Tirumurthy? From Michigan. Okay, for some reason, it's not here. All right, so a lot of us got introduced to a lot of changes. I call that as inflection points, right? Back in 1879, we had electricity discovered, right? Positive and negative charges and so forth. For over, we're going to have 2 centuries, we got immense benefit in terms of application. So electricity became a raw material, right? During our time, back in mid-90s, many of you practitioners, right? I managed my wife's practice for 20 years. We only practicing in the front office, managing activities and so forth. So I can firsthand appreciate what to expect in the future. So before I ask, how many of you have private practice? Please raise your hand. Okay. How many of you work for hospitals as a specialist or on staff? Okay. Academicians. Okay. Very good. That's a very nice mix of population. So let me go back to the previous question. Mid-90s, right? We had an inflection point. Internet came into being, right? We did not have VMware, right? We did not have object computing. 1995, 96, 97, which was for Center of Excellence for commerce, if you will, digital thanks to things of that nature in Pennsylvania. In the last 20, 25 years, things that we do are dramatically significant from what we did before that, right? You all can acknowledge that fact. Now we are at the point, right? We start talking about AI. If we felt that the change was so significant in 1995, 96, not even knowing what to expect, believe me, folks, it's going to be a factor of million, if you will, relative to what we witnessed back in 1995. That is how we. Now let me ask you another quick question before I get into the slide. How many of you think this AI, pivot into the AI, is an opportunity. Please raise that. Excellent. How many of you think, oh, it's going to challenge me, maybe I will lose my job, maybe my practice will go down? Please be honest. Raise your hand. It could be as simple as maybe we need to get to know a little better. Okay. All right. Let's get it. I think I see majority of you seeing this as an opportunity. So I'm going to go in detail a little bit and see whether we can address some of your expectations. AI, nature, very high level, is building systems that simulate human cognition. Put it up. People could interpret it in a lot of different ways, but what we have been doing historically, right? As a human being, the cognitive function, we are blessed to use on a daily basis, recognizing an object, a picture, differentiating different things. Within a matter of seconds, machines are now trying to do. What happened in the Industrial Revolution, Revolution 1, when we got electricity, when we had mass automation back in the early 1900s, for example, when the Ford T model came in, electricity was there, we were producing automotives over and over again on a repetitive basis. A lot of what you call efficiency was seen in operation. Well, still we have unemployment just 4%. Automation didn't really take care of the job. If you have that mindset, how AI is going to help, okay, how can it augment what I do on a daily basis so that productivity can go up and I can give a lot of value service to my customer? I'm happy overall everyone knows the process. What's happening? What is the risk factor for some of the cardiovascular positioning, some things like that. So we are really getting to different realm of intelligence to speak, particularly when we use machines. So in the process, we have machines, okay, that have to be trained for certain things to happen. One is supervised learning, the other one is unsupervised learning. As the name goes, supervised learning is machine is dumb, it does not know. So I have to tell, this is Tom, this is chicken, this is rooster, whatever that is. So that is called supervised learning. We keep training the model over and over again using trillions of data. Then when I introduce a new set of data, it recognizes based upon some patterns and so forth that is trained up. On the other hand, I also have what's called unsupervised learning. It's very, very hard for me to even put a rule how the outcome should be defined. In that case, the machine, okay, looks at several data points, trying to figure out what the patterns are, and tell us at a very high level, categorizing it. So we call that as unsupervised or clustering. Okay, a lot of radiologists probably know by now. Clustering is used in a lot of different ways. We have reinforcement learning, a lot of other things. We are also hearing all this these days for natural language processing. Anything, the method that we use to interact with machines, whether it's voice, text, whatever, that falls in the category of natural language processing. And obviously, we have computer vision and so forth. Generative AI is a little bit advanced. I'll get to that in a minute. So machine learning, as I said, machine learning learns on its own. I do not have to program, but we still have to lay out some foundation before it starts working on its own. Supervised learning, unsupervised learning, as you could see. Supervised, you give labels and say cat is cat, dog is dog. On the other hand, unsupervised learning learns on its own. The challenge is, how do you really generalize? You train a very complicated data set, okay, using some labels or, can you see that?
You're showing your back too much. You can go on that side and speak. Yeah, try to speak this way. Yeah, you're showing your back to the camera.
Thank you. So generalization is a little bit difficult, and I'm going to show you a few examples as we go through. As I said, machine learning, you really don't have to define a structured set of rules, if you will. When you have these kind of opportunities, for example, the data set is very complex, very difficult to put in set of rules. Data availability, when you have very high volume of high quality data, and you want to label them, and want to have some clear predictive objective, then that is a good candidate. And the unstructured data has got a lot of what you call complexity in terms of the diversity of the data itself. You have text, for example, you have blog, you have image, sometimes audio files. How do you really set rules for them, right? So the machine learning method really helps a lot. Adaptability when the operation environment is very dynamic and the model needs continuous improvement and so forth. So this is at a very high level, inspired by the brain anatomy function. We have input layer here, as you can see here. So a lot of features of kind of products you want to replicate. For example, if it's a cat, I want to train the machine. Hey, it is a cat, it is a dog. What are some of the features that I need to input? So it could be whiskers, it could be 4 legs, it could be fur, whatever. So those are called the features. They go in, and you have a lot of math here. These are essentially neurons, and you have some connections between the input and the middle layer. There could be multiple layers here. Then you have the output. I have a good example to show. So for example, this is the model I'm sharing with you, where I'm trying to train this neural network to recognize whether it is a blueberry or strawberry. Okay? How does the system know it is strawberry? I need to really have some kind of what's called the vector definition. So let us say I want to define this as round and make 2 separate pictures and maybe color. If I put that in and it goes through this processing network, and if I have the output, if this is that is the target node, I call that as strawberry. If this is 0, obviously that is not strawberry. If I put, for example, blueberry through this network, if this is 0, this is 1, and this is my target state, I want that to be defined as blueberry, the machine learns. And any connections you have in between, there could be multiple layers. These network, if you will, that connects these neurons are called weights. We get to hear all the time, parameters, parameters, parameters. How many of you have heard from Jensen Huang, for example, in NVIDIA? I have billion parameters for my model. Have you ever heard of that? Right? So those parameters, when these senior leaders talk about, are nothing but these weights. Okay, so I have another slide to show here. There's a little math happening. I don't want to, take you back to your school days, but there's some sigmoid functions and whatever are happening here. So every single neuron has got some math function. When I send blueberry, this is the characteristics, all the features I input. There are some connections with the output. As you can see here, I have 0.95. Okay, initially when I train the model, and this is 0.09. So the way I train the model is by tweaking these weights, okay, such a way that the output is either 1 or 0. And that happens, then I know the target state blueberry is actually. Okay? So think about different types of blueberries, different lengths, different dimensions that would come my way, and I want to train the model. So when I put a bunch of data and train, and introduce, for example, a new set of parameters for strawberry or blueberry. So I'm not going to go in detail what happens within the neuron. There are some weights here, there are some bias and things like that are happening. But at the end of the day, what you're really expecting using this math is either 0 or 1. 1 is the target state. Until such time you achieve, you the training process, you tweak these weights. That's essentially what happens to the network. So a lot of people think it's a black box. There is some method to the madness as well. A lot of people do not tell you the detail, but a lot going on within the black box. But this is at a very high level to understand how neural network works. So I said features are reporting strawberry and blueberry, right? Roundness or length, whatever. If I have a situation like this, a lot of animals, okay, I'm training my neural network. Tell me a little bit about whether they are reptile or not. That is the problem I want to solve. In order for me to solve the problem, I need to provide the model with a feature, right? So what some features you can think of? Can anyone guess what some features you can think of to train neural network? I know. What? Scale? Feet? Okay, that's enough? Legs? Yeah. Excellent, excellent. These are the features. To train neural network model, you need to know the neural features, right? In the next slide I'm showing you, okay, I have all these animals. These are some features I can think of, and my problem is whether they're reptile or not, right? See, for example, cobra, all are checked here, yes, it's reptile. But look at boa constrictor. They are not egg-laying, they're not poisonous, but still they're reptile. Think about the challenges, the complexity, the inconsistency. So when you see a neural network giving some results in certain domain, we cannot generalize. Go back to my first slide. The challenge generalizing certain prediction. So that cannot happen. So what is important here is when you're trying to select set of features, you have to be very cognizant of whether that is the right set of features. You do not want to overestimate the number of features at the same time, you need to have a finite set of numbers. Again, this comes from my good friend Eric Grimson at MIT. This example has been taught for computer science students, undergrad, at MIT. Okay? It really conveys the point so well, so beautifully. Features are essential paramount to train models. In your scenario, right, the healthcare setting, for example, if these are patient input data, consider them as a feature, right? Feature set, you have some learning model, you black box, you're trying to assess the low risk and high risk, etc. Based upon what I just showed you in the previous example. That is supervised. You really say that when certain input is given, you define like a strawberry or a blueberry, this is what it is, and apply that for trillions and trillions of data sets. On the other hand, if I have certain information that are not labeled, okay? For example, genomic data or physiological sensors, you have to watch and a lot of things coming to you, data set, and clinical information. If you put all of them through the model, what the system does is looks at the features. Okay, let's say cat, I've got features for cat. Thousands of cats have the features that are fed to the system. Thousands of dogs, for example, their features are set to the system. So it recognizes the pattern between these feature sets, if you will. To be very honest, what really happens is the proximity of these features, distance between feature A and feature B between an animal. So it really comes with some kind of phenotypes for patients. So beautifully done. And again, it just clusters them, group them in separate sets, if you will. A lot of things have happened. Chat GPT moment. Can anyone tell me what was the moment? Which year it happened? Chat GPT moment. Chat GPT moment. What? 23? Okay. Yeah.
2016.
Exactly. Around 2019 and 2020, there was again a big inflection point. Again, OpenAI didn't do overnight. A lot of incremental steps done over a period of time. Our own guy, okay, Ashish Pushpani, he led a team at Google, okay, built on a model called the attention model, okay, that was that was put together back in 2015. He built on it. What he did was very interesting. When you try to train the system, you don't have to overwhelm the system with a lot of unnecessary information. You only pay attention to the what you call the neighborhood, the details, if you will, the meaning, and they're trying to connect them. I want to show you a good example. The architecture that we came up with is called the transformer architecture. So, for example, if I put in information, this is how you say it. Then any French-speaking person here? Okay, I'm going to take a chance here. You also ST Beyonce, okay? My friend, excuse me if I'm incorrect. So when you put that information, what happens is, in Gen AI, people talk about tokens. So whatever input you give is broken into small components, whether it's a word, character, or some text. It's sent through this big architecture, a lot of different modules. Encoder finds meaning. The decoder takes that and tries to associate with the future target expectation, and it comes in output for IMS student. So this is the translation. This is the black box. So a lot more is happening within this. We talked about Gen AI, it came in 2020, 2021, using natural language processing. Interesting. Look at what happened. This is back in 1966, 1964, right? In MIT laboratory. They came up with the psychotherapist trying to do natural language processing. I put in some text, then I get some response back. So in order to give some emotional care, and this system was introduced essentially based on text information. It took so long, 1966 until 2020, to see what we see in the form of bot from Google, or Gemini from Google, or ChatGPT from OpenAI. So I want to show you a little bit about the market. This is Professor, I care about what's really going on. See the hyper growth here. Unbelievable. By 2030, on a global basis, they're talking about 240 B. I bet it's not even 240. It could be $1 trillion business opportunity on a global scale. It's amazing. There are a lot of references if you're interested, you can see. And these are some areas, right, where AI gets used. Administrative tasks. You have to have management responsibility, front office. Right now, as we speak, right, 35% administrative task. When somebody checks in and come in, okay, validating the credentials of the patient, the insurance papers, etc., etc. Things of the nature gets a lot of priority to the medical imaging. A lot of radiologists can vouch for it with 30%, as you could see that. Even drug discovery, a lot of attention being paid. It's amazing what is happening. The pie is going to expand. The pie is going to expand, and we are going to see a lot more activity in a lot of different sub-areas. AI-powered drug discovery. Some of you probably may be very intimately involved. As you can see here, target identification, time reduction. It takes maybe over 12, 14 years to come up with a commercially viable, right, molecular formula, if you will, to see some return on the investment. And using this AI, we are able to dramatically reduce the discovery time, if you will. Identification, lead optimization, pre-clinical testing, etc. There are some examples here. You probably may be very familiar with DSP 1181, for example. That is for obsessive compulsive disorder. Similarly, we have another one here in silico. I think that people were collaborating both from UK and Japan to pilot that trial. Diagnostic accuracy is amazing. As you can see here, breast cancer detection. The dot grid. This is AI, again, AI assisted diagnostics. It is at least as close as having the standard care that we expect to radiologists. So breast cancer, diabetic retinopathy, trying to be upfront, trying to be very conservative. Tools are available now, and we have a pneumonia diagnostic data. And there's a different form of neural network being used. It's called the convolutional neural network. It's again part of machine learning, deep learning, but it focuses on imaging. That's what you really need in mammogram application. All right, so I want to share with you a small case study here. Massai trial study. How many of you are familiar with this? I know for sure all our radiologists know that. So this study, patient trial was conducted in Sweden, southwest Sweden, 4 different sites. So very interesting. As you could see at the very top, we're talking about randomized, controlled, non-inferiority. The going in hypothesis is AI, okay, assisted diagnostic is not going to be inferior to having a physical radiologist. So that's the hypothesis. And the results came out as they expected. Single blinded and the screening accuracy study. This is the setup, okay. As I said, it was done in Sweden, the 4 site. And it's a regular routine checkup. If somebody had breast cancer already diagnosed, they were not qualified, so they were removed from the study, 40 to 80 years, as the kids are randomized trials. And what happened was they took the mammogram, and the randomization was done, and both the tech and the patients were not told when the image was taken, mammogram, and they processed it through the AI. Again, there is a decision point, and when half of the patients went through the AI procedure, the system they used was, as you can see here, transparent. It really came up with the scoring 1 through 10. Okay, high risk 1 through 8 is medium or moderate risk. 9 and 10 is high risk. If that is the case, then how many radiologists will see? I will show you in a little bit. There are some other details here as well in this trial. So randomization done after the fact, after the images were taken. This is a prospective study. This is the control group. For some of you not really intimately involved in academia, control group is they don't get treatment. An intervention group, people get treatment, right? So half of them go here, half of them go here, and this is the risk score. The machine that they used to transfer came up with between 1 through 10 is risk score, and anytime the risk score mammogram is between 1 and 9, they go through single reading. It's one radiologist to read. Okay. Again, the final decision is not given with just the AI machine. When the score is 10 high risk, then it goes through double reading, 2 radiologists. That's the standard of care, right? The control group where there's no intervention done, no treatment, we have double reading as usual without the AI. I want to show you a very high on some population here. Again, you may not be interested at a very high level. We can see 50% of the population. This is what would excite you. So 39,000 folks, went through this intervention group where treatment was done, right, with AI giving the score, and equal amount went through this control group. Number of recalls, they highlighted some anomaly, okay, the tissue, whatever the pattern recognition, we saw that, right? So machine highlighted 861 cases required further evaluation, assessment, maybe biopsy, maybe something else, maybe another ultrasound, maybe another MRI, what have you, right? So these patients have to be reassessed, and you could see the number 861, 817, again given the size, no big deal. Recall rate is again almost the same, whether you go to AA model or you go through the regular path with the two radiologists, the same. But what really caught my attention is the number of screen detected cancer, okay, for equal number of patients, almost population is 244 here at 203. So it was able to detect more cancer in the study. Similarly, the cancer detection rate per 1,000, this is what epidemiologists are very familiar with. The percentage report is always for 1,000 people and so forth. It is 6.1 versus 5.1. So this is very interesting. It shows the effectiveness of the treatment procedure. And the false positive is almost 1.5. We don't want any false positive, right? Giving a lot of shock to the patient, so we want to be very careful. So this is, we want to make sure. AI system did really create a lot of issues. Positive predictive value, this is again 28.3. This is essentially, this divided by number of screen detected cancer divided by number of recalls, right? People are coming for reassessment 861, and people are found to have breast cancer 244. If you have simple math, it comes up as 28.3. That's interesting. That is the effectiveness of this machine, right? Machine learning models. So pretty interesting, very high rate. And the number of screen readings, 46. Number of screen readings, let's pay attention here. 46,000 readings. In this case, without AI, I have huge workload, 83,000. Think about that. That is what you will be interested in as a radiologist. If I have an AI machine, that's going to help me. Your workload is going to go down, right? And we see other positive factors here, predictive value and so forth, regardless how many readings I have. It's almost half. Right? So, if you really want to leverage this tool, there's a lot of benefits there. And this is again the risk score. So, some of the takeaways are, as I said, there is significant gain in the workload. What that means is we are releasing our wonderful, well-trained radiologists to do what they can do for people who otherwise would be missing their chance. So, if you think we're going to lose jobs, and many of you said no, right? You said a lot of opportunities out here. I concur with you. Tools are essentially to provide additional efficiency, right? Like a simple lever, you see it at the top, right? So tools, technology is there to help us gain efficiency. As the physician, you're going to see a lot more efficiency. And one of the themes that is going around now is called agentic AI. All the workflow you see in your front office or triaging, right, when patient comes in for some care in the hospitals and so forth, are going to be automated in the conventional organization chart, the vice president, managers, staff, and so forth. Believe me, folks, in the next 5 years, you will see some blank boxes. That's going to tell you these are AI tools, automated tool. If you provide some input, that's going to be everything. Checking the incoming patient's insurance information, their vitals, it may take a lot of different things, and it will connect the loop between even send reimbursement claims to Medicare and so forth. And you may wonder, hey, I have a boatload of people sitting in the front office, what should I do? Right? So be ready. You're going to be managing that situation. And believe me, it's not very far off, right? I said what we saw back in 1995 when internet came into being, it's going to be million times more than what we witnessed in our life. Okay? So with that, I conclude. I have a lot of other things to talk about, but in the interest of time, I know my good friend is signaling me. I want to be very respectful to him. This is the upcoming book. First book is Business Innovation. We released like 4 years ago. The second one is Integrated Business Innovation. I know that my wife is on the Jake Moore, again, a staff. sleepwalker with me. So with that, thank you all. Appreciate it. So get done or?
Yeah.
Okay. Thank you so much. I'm available next 24 hours. Feel free to interrupt. My style is a little bit different. We have a theatrical performance at a business school. This is how we teach. I wanted to give you a feel for it. Okay. Thank you.
For our next speaker, we actually are very lucky to have a last minute fill for an empty position. So we have Punita Vijay Kumar. Thank you. Oh, yeah. Okay, good. So her topic is going to be on obstructive sleep apnea, a new perspective. So Punita is actually a 1983 batch. She trained in neurology at Case Western and went on to do a fellowship in clinical neurophysiology, epilepsy, and sleep at the University of Michigan. She's currently on faculty at the University of Michigan. And so she's an expert on sleep apnea, and we're looking forward to listening to you.
Thank you so much. This is, are you able to hear me? Okay. Yeah, it's a last minute talk because somebody else didn't show up and I got my time. Thank you. So today I'm going to talk about obstructive sleep apnea, the CPAP therapy, alternatives, something new that's available right now. So I want to know how many of you have snoring? Okay. How many of you are diagnosed with obstructive sleep apnea? Not many, I guess. I can tell you that. And how many of you are using the PAP therapy, the CPAP therapy? Yes. How comfortable are you using it? Good? Every night? Oh, your wife doesn't like it. Okay. I mean, often we see in the clinic, the males don't come on their own. It's because the wives are nudging them to go to the doctor and ask for, my husband is snoring. Very rarely, the females come to the sleep physician to talk about sleep apnea on their own for themselves. Because often you see sleep divorce, when they start snoring, they go to two different rooms and sleep. Now they've expanded the apnea-hypopnea index to 65. BMI was only 35 before, now it is expanded to 40 BMI. So it's still effective. Since those post-marketed study with the higher BMI is mostly from Europe because we strictly followed whatever the data that inclusion criteria that we used in our trial here. The INTERA is another study that another company which is using, it's called Orantic 6000, and that's a Genius system which is going to be approved. It's approved in Europe, it's not done in the United States yet. That system, you don't have to have it, the Inspire device stimulates unilateral hypoglossal nerve. This one stimulates a bilateral hypoglossal nerve. I'll show you a couple of them. So this is the Genius system. That means you put the electrode in the middle of your chin, inside, and there's an external adapter which you put it on when you go to sleep, and that stimulates from outside. This is a Genius system, and this is the one it's approved in Europe. It's going to come here. In our institution, we have not done any one so far. So the hypoglossal nerve is really helps. So this is the device. You have an electrode and you have the Inspire device. It's similar to the pacemaker, and you have a remote, and that has about 3 electrodes. You modulate all the 3 electrodes when you do the setting, and you turn it on at night, and we can set the parameters how long to be done, meaning to be on, and in the morning either you switch it off or you switch off automatically. If you wake up in the middle of the night, you will be slurring of speech. People do call EMS for stroke, so you have to be watchful of that. You cannot drink water when the system is on. You can pause it, and otherwise you get into regurgitation and aspiration. Currently, it's 18 and over. Whoever is fat intolerant, 50 to 60 hours AHI, it has gone up to 100. BMI has gone up to 40. You have to have a DICE. Anybody with ENT physicians know what is DICE? It's a drug-induced sleep endoscopy that they have to do, and it has 2 incision. The most recent model needs only 1 incision because it's accelerator based. The second incision is for the lead that goes to the respiratory muscle. It's not there right now. In the first one, it had 3 incision. Then it went down to 2. Currently, the newer model has only 1 incision. They put the pacemaker there. And that has accelerometer which recognizes your inspiration, then it gives you stimulation. And this is what we call the Inspire device. Is there anyone who can help me in that? There's a criteria. If your AP collapsed, your uvula and the posterior pharyngeal wall collapses this way, you're good to go for the Inspire device. And this is the AP collapse. You can see if you put the endoscopy there. And if the concentric collapse happens, you can see the one to my left. That's a stable lateral wall, just the anterior posterior wall is collapsing. You are a good candidate. If your whole pharyngeal wall is collapsing in a circumferential fashion, you are not a good candidate because the idea is pulling your tongue out. That's the therapy. It is approved in a pediatric population only for Down syndrome patients. So it is very effective. We know the pediatric population sleep apnea is treated after with the adenotonsillectomy, and you know that kids don't like to use any kind of tap therapy, particularly in Down syndrome. They have a facial features and a large tongue. They are very high risk for sleep apnea. The adrenal registry is still going on. It's very effective. You are not curing the sleep apnea, reducing the severity. So when they come after the sleep study, they're expecting most of them, I'm still snoring. Sometimes they come and tell you if the snore is coming from the top of your nose area. The phrenic stimulation therapy is something that we use for central sleep apnea. Obstructive sleep apnea is in the tongue base. Central sleep apnea, it's the brain. Your respiratory system doesn't work, your thoracic wall doesn't move, your abdominal wall doesn't move, your diaphragm doesn't move. So you're in a complete obstruction right from the top to the bottom. So phrenic stimulations, there are certain indications. Congestive heart failure, mostly cardiac, stroke or idiopathic central apneas, we use it. We don't use the phrenic stimulation for OPI use. If anybody uses the OPI, they're also prone to have central sleep apnea. And it's done by the invasive cardiologist, interventional cardiologist, who can put those electrodes into your right brachiocephalic ascendus vein. That's where it goes in there. And you have a pacemaker kind of a device outside, and we stimulate that. And you can see that in the first part of the.
Okay, thank you.
You have a central sleep apnea. This is, everybody knows. You know what type of respiration is, chain stroke respiration. You breathe. Intensity goes up, shallows, obstruction, and in every part of your thoracic wall, in your abdominal wall. And then once the stimulation therapy is on, your normal breathing. And I'm going to. Now we have. Okay, that's fine. Thank you. Now we have a GLP-1 as FDA-approved medication for obstructive sleep apnea. It is effective by reducing the weight and also decreases by 50% of your sleep apnea index. Now we also have another trial going on for your atomoxetine trial, which is also helpful in sleep apnea. So these medications are adjuvant to your other therapy, not a primary therapy.
Good afternoon, fellow Stanleyans. I'm so proud to be here today. I also listened to all the preceding speakers. I'm so proud to say that those following graduates have done an excellent job, and I really enjoyed your talk, and kudos to you all, and hope I could do the same, the quality of my talk would be the same as you guys have done it. Today my talk is going to be on massive D, MASH and treatment. I know in the audience some of you have questioned me why the nomenclature have changed. Can you take it to the mode? Yeah, I can. Okay, so I think my second slide says, "Love your liver." Liver is the center of universe. But after listening to all my preceding speakers, I have to modify that. Every organ is important, but liver is the organ that speaks to all the other organs. And I'm very passionate about liver. I think that slide sums up my passion. And I'll start with you as patient I saw on Wednesday. This is a 65-year-old lady who is the CFO of an insurance company, walks into my office with thank you. With her husband in a panicky way. She was referred to me with a fibroscan showing fibrosis score of 14.5 kilopascal, which indicates advanced fibrosis or close to cirrhosis. She was in tears, and she also complained that 10 years ago, her PCP said, "Oh, you have a fatty liver, don't worry about it." Nothing was done. And now I am here in front of you with stage 4 disease. When am I going to have transplant? And she was so panicky. And I calmed her, and I also told her this is the same story I hear from most of my patients who are referred to me. Why so? Because there's a huge knowledge gap among the practitioners, at least the community-based practitioners, and the steatotic liver disease. Rewind, in 1980, we are observing some patients called non-alcoholic fatty liver. These patients never drank alcohol. They have certain risk factors, and we observed these patients develop fatty liver, and some of them progress to cirrhosis. But now fast forward, it has taken another 3 or 4 decades for us to identify these patients. The reason being, most of the hepatologists, the past 3 decades, were focusing on Hep C and Hep B treatment. Once we took care of them, once we found a cure, now all these patients are coming to the surface. Now, why the nomenclature was changed from NAFLD to MASLD? This was actually driven by the patients' advocacy group. Patients' advocacy group felt that calling them as an alcohol, the word alcohol, and fatty is stigmatizing them. So they wanted to change it. And it took 3 years. All the organizations, both the ASLD, EASL, Apostle, and Latin American Liver Organization, it took 2 to 3 years for us to come up with a consensus to change it to MASLD. MASLD stands for Metabolic Dysfunction Associated Steatotic Liver Disease. And it makes sense. Metabolically, that's what happens. I already have shown you this slide. This is my disclosures. Now, this is my educational objective. I'm going to review the epidemiological impact of MASLD. I'm also going to discuss with non-invasive testing for MASLD and MASH. And finally, I'll explain some of the lifestyle modification and currently evolving treatment as well as approved treatment for MASLD and MASH. The new nomenclature, once we have come up with the new nomenclature, I wanted to all focus on the 5 buckets. Now, starting from the left hand, it's metabolic dysfunction associated steatotic liver disease. Hereafter I will call as MASLD, which can progress to MASH. By definition, MASH is a histological diagnosis. You do a liver biopsy. Liver biopsy would show steatosis along with some lobular inflammation and ballooning degeneration and certain fibrosis factors. That's called MASH. And the MASH would progress to fibrosis and cirrhosis. That is the first bucket. The second bucket is called MET-ALD. MET-ALD is a new evolving concept. It's a new evolving phenotype we are observing. Some of these patients who have underlying metabolic dysfunction associated steatotic liver disease, they also drink alcohol. Based upon the quantity of alcohol they drink, the MET-ALD, MASLD predominant, or if you move to the left, ALD predominant, based upon the quantity of alcohol they consume. In the males, 30 grams per day. In the females, 20 grams per day. They consume alcohol. They are considered as MET-ALD, MASLD predominant. If they consume 50 grams among females, 60 grams among males per day, they are ALD prominent MASLD. Of course, you all know about the third bucket, alcoholic liver disease, and fourth bucket is specific etiology. Some of the medication can cause tamoxifen and methotrexate can cause steatotic liver disease. And some of the diseases such as Wilson's disease and alpha-1 antitrypsin deficiency disease also can cause steatosis. And of course, the fifth bucket is SLD or cryptogenic steatotic liver disease. But today I'm going to focus mostly on the MASLD and MASH. So when a patient walks into your office, either you did an ultrasound and you found steatosis, or for some other reason they did an ultrasound, you found steatosis, you want to ask one of those 5, does the patient meet any one of those cardiometabolic criteria? I'll walk you through that because it's very crucial to know those 5 factors. Number 1 is BMI. If the BMI is above 25 25 among non-Asians, Asians it is 23, fasting serum glucose above 100, or the post-prandial above 140, or the hemoglobin A1C above 5.7, or if they are on treatment for type 2 diabetes. Point number 3, if the BP is around 130 or 85, or they are on antihypertensive medication, or if they have plasma triglycerides above 170, plasma triglycerides above 150, or the plasma HDL less than 40 milligram, or if they are on lipid lowering agent. They meet one of those 5 criteria, and you ask the next question, do they drink alcohol? If they don't, they fall in the category of MASLD. Of course, you always want to take the history of how much alcohol they consume to put them in the category of MET-ALD. Now, this is the current and growing prevalence in the world. You all have heard about, the MASLD is becoming as epidemic, in epidemic proportion, we are seeing these cases. Most of the primary care physicians would see patient walking into their office with steatotic liver disease on ultrasound. Globally, it is 30% of the population has it. Now, if you stratify them based upon different regions, Latin American population almost 45%. The MENA stands for Middle East and North American cohort. They have almost like a 34%. In India, it is 30 to 35%. Now, if you look into the diabetic population, in the North American cohort, almost 2/3 of the type 2 diabetes patient has MASLD, and 5% of them will progress to MASH. Once you develop MASH, there are higher chances to develop into advanced fibrosis and cirrhosis. So this is the natural history of MASLD, starting from left to right. Once they develop steatotic liver disease, based upon the stages, you could give the prognosis. most of the time when a patient comes and sits in front of you, they'll ask you the question, Doc, how long I have? When am I going to develop fibrosis? It depends upon the stage of fibrosis they are showing at your office. For instance, if they are stage 0 fibrosis, it takes almost 35 years to develop cirrhosis and decompensation. If you have stage 1 disease, 25 years. Stage 2 is 15 to 20 years. If it is stage 3, it is 10 years. Stage 4 is 5 years. Now, once they develop cirrhosis, for them to develop hepatocellular carcinoma, it's almost 2.3% per annum. We are seeing more cases of HCC secondary to MASH-induced cirrhosis. Now, this is another pictorial slide stating that if you have stage 0 to 1, it takes 35 years. If you have stage 2 and above, it takes to 15 to 20 years to develop cirrhosis. Stage 3 and above, 5 years. Why it is very crucial? Because you want to know your patient sitting in front of you, what stage of fibrosis the patient is at, so that you can plan the treatment modality. Now, if you look at the long-term outcomes of the mortality in MASLD, just I'll point out the death rate among all causes in general population is 8.3 per 1,000 person years. Just having MASLD alone, it doubles, the mortality rate doubles. If you look at the MASLD cirrhotic patient, death rate among general population is 8.3 per 1,000 person years. If you look at the cirrhotic patient, it almost multiples by 9 times, 75 per 1,000 person years. In other words, having a cirrhosis itself increases MASH cirrhosis, increases the mortality. So we have to pay attention to our patient with MASLD and fibrosis. Now currently, if you look, at least in US, the liver transplantation for alcoholic associated liver disease is around 48%. Look into the NASH, over the past 10 years, for the past decade, it started at 19%. Now it has grown up to almost 30%. If you look at Hopkins, I would venture to say 35% of patients who comes for transplantation is due to MASH. And look into the graph of chronic hep C. 10 years ago, when I gave the talk, it would be almost 1/3 of the patient came for liver transplant. Now it has significantly fallen down to 4%. So, I could say that I've been part of the whole treatment starting from almost from 1998. And that's a rewarding feeling for us to find a cure for hep C. We have changed the natural history of the disease, and we have had a huge impact on our population. Look at the chronic hep B. With an effective and efficient treatment, the liver transplant has remained very low, but MASH is increasing. What we are projecting in the next 20 years, the prevalence of MASH fibrosis, MASH cirrhosis, and MASH liver-related mortality is going to increase. That will translate into both economic burden, as societal as well as an individual. It might either double or triple or quadruple. So we have to take this into an account, and we should start doing something about patients who comes into our office with metabolic associated steatotic liver disease. Now this slide is very crucial. Why? Based upon the stage of fibrosis, when a patient walks into your office, one could determine the prognosis. If you look into that stage 2, the chances of the liver-related mortality based upon some meta-analysis studies is 2.5 times. If the patient with the stage 3 disease, it is 6.5 times. And if you look into the all-cause mortality, not just the liver disease mortality, it also increases based upon the fibrosis staging. So it is very prudent, very crucial for us to determine when a patient walks into our office at what stage of fibrosis the patient is at. Now, what about if you reverse the fibrosis, can it alter the course of the disease? Answer is yes. Based upon the Stellar 4 trial, it's a simtuzumab trial. Though the clinical trial did not meet the endpoint and it failed, when we did the ad hoc analysis, if you look at the graph, those patients, as indicated on the green bar, those patients who reversed fibrosis by stage 1, there's a significant drop in the clinical outcome towards the better, as opposed to those patients who progressed liver fibrosis, as it is pointed out on the brown board, 7.2% over a period of 48 weeks had liver-related events. So in other words, there is enough evidence to show patient who is coming with advanced fibrosis will progress to cirrhosis, and it will increase the liver-related mortality and all-cause mortality. And if the fibrosis regresses, it also has a better outcome. It changes the natural history towards the betterness. Pathophysiology. I'll take just a few minutes about that. I can talk for a whole hour on the pathophysiology. The liver, the hepatocyte, the fat accumulates in the liver through 3 ways. Number 1, from the peripheral adipocyte. Number 2, through the dietary mechanism. Number 3, de novo lipogenesis. Once the fat accumulates in the mitochondria, the beta oxidation takes place, and then the fat gets metabolized, and it gets excreted through the VLDL mechanism. This is the natural phenomenon, natural physiology. But what happens in MASLD, the increased amount of fat gets deposited in the liver, so the mitochondria gets overloaded, so the degeneration of mitochondria takes place, apoptosis of mitochondria takes place. This then eventually it leads to the apoptosis of hepatocyte, the cellular death occurs. We call them as a damage-associated molecular proteins or patterns recognized by resident, the Kupffer cells, resident macrophages and wandering macrophages. So those macrophages, recruited, and they liberate cytokine called TGF-beta, which stimulates the hepatic stellate cell, produces the extracellular matrix and fibrosis and cirrhosis. Now this is so important to know the non-invasive, biomarkers. As you know, if we have 1/3 of the population has steatotic liver disease, we cannot biopsy them to stage. So we have come up with non-invasive testing. There are 2 blood-based biomarkers, FIB4 and ELF, and 2 radiological-based biomarkers. That is vibration controlled transient elastography or fibroscan or MRI-based. The FIB4 is very easy to do in your clinic. When a patient comes into your office, what all you need is 2 parameters: age, AST, ALT, and platelet. There is an app. If you plug that, FIB4, if you calculate the FIB4, if it is less than 1.3, the probability of the patient having advanced fibrosis is very low. If it is about 2.67, the patient has got higher chances to have advanced fibrosis. If the FIB4 is above 3.25, the patient has got cirrhosis. What about ELF score? ELF score is enhanced liver fibrosis score that takes in 3 parameters or 3 proteins. One of them is hyaluronic acid, which is the extracellular matrix. The other one is the procollagen 3, it's a fibrosis marker. The other one is called a TIMP1, which is actually a fibrinolytic enzyme. So by measuring these 3 parameters, one could come up with a scoring system called enhanced liver fibrosis. If you are less than 7.7, it's a proprietary, LabCorp does it as well as the Quest does that. If it is less than 7.7, it is early to know fibrosis. If it is above 11.3, that patient has got next 4 to 5 years, they'll get into liver-related mortality. Whereas above 9.8, they have advanced fibrosis. Fibroscan, I believe, or I think, and I always say that Fibroscan is a stethoscope for a hepatologist. What is Fibroscan? It is actually based upon the technology is based upon the ultrasound. If you pass the sound wave, the fat gets actually absorbed, the sound wave gets absorbed in the fat, as well as the stiffness. Based upon the stiffness of the fibrosis, there is a conduction of the sound wave. So by looking into the slope of the wave, one could determine what is the scoring. Now, the fibrosis score is actually kilopascal. If it is less than 10, it is mild fibrosis. Above 10, it's an advanced fibrosis. If it is above 15, those patients have cirrhosis. What about MRI? MRIs can determine how much fat patient has based upon MRI PDFF, and MRE, MR elastography, can determine how much stiffness patient has. And based upon that, one could determine the stage of the fibrosis. The patient has got about 3.64 kilopascal. That means this patient has advanced fibrosis. Now, for the want of time, I'll skip some of the slides. My next few slides indicate that you can use these biomarkers to predict the outcome based upon at what level you see the patient at the base level. FIB4, transient elastography or fibroscan, ELF. Now, just let me walk you through this for ASLD practice guideline. Just to focus on this, on the left-hand side. The square, the purple square, if a patient comes into your office with, steatotic liver disease, do the FIB4. If the FIB4 is less than 1.3, if the patient has diabetes or any other cardiometabolic risk factor, bring them back every year and monitor them with FIB4 or with the liver enzymes. If it is about 2.67, send them to a hepatologist or gastroenterologist. If it is in between 1.3 and 2.67, you do a fibroscan. If the fibroscan is less than 8 kilopascal, bring them back to your office. If it is above, send them to the gastroenterologist or hepatologist. Now, these are some basic numbers if you want to remember them. On the left-hand side, FIB4, if it is about 2.67, ELF score about 9.8. Imaging, transient elastography about 12 kilopascal, MRE about 3.63 kilopascal. This is the cohort. They have advanced fibrosis. This is the cohort you want to treat them with currently available treatment. So let me move on to the treatment. Next few minutes I'll take maybe 3 to 4 minutes. What is the first step in treatment for MASLD? Weight loss, number one. Weight loss based upon, weight loss actually, the next is the diet. The third is the physical activity. If you lose 5% of your current body weight, you can reverse the steatosis. If you lose 7% of body weight, you can reverse the inflammatory change. If you lose 10% of body weight, you can reverse the fibrosis. Now, what kind of diet? We actually, we encourage Mediterranean diet based upon evidence. What about exercise? We recommend 150 minutes per week, moderate exercise. I think Dr. Kusum Lata mentioned about diet and exercise already. Now, this is actually, when they compare to all the diet, Mediterranean diet, ketogenic diet, low-carb diet, as indicated in the green circle, Mediterranean diet has a better, evidence for reversal of steatosis and steatohepatitis. Now, based upon the study, they looked into the 6 weeks to 6 months on Mediterranean diet, liver stiffness, HOMA-IR index or FLI, fatty liver index. Mediterranean diet is the one that performed much better than all the other diets compared. What about intermittent fasting? There are 3 types of intermittent fasting: alternate day fasting, 5 days of diet, 2 days of fasting, or time restricted eating. 12 hours. I always tell my patient, time restricted eating is much better, or at least one could do it in practice. 12 hours of fasting. If they have dinner at 6 or 7, I always recommend them to have breakfast after 7 in the morning. So it's a 12-hour of fasting. What about the physical activity? 150 minutes per week moderate exercise or 75 minutes per week of intense exercise have been proven to show reversal of liver fat, but not hepatitis, steatohepatitis, not fibrosis. So let us move on to the current pharmacological treatment for MASH. Currently, we have a drug approved called resmetirom. It is THR beta agonist. I don't want to go in depth of it mechanism because of want of time. It is approved last year for those patients who has moderate to advanced fibrosis, stage 2 to 3 fibrosis. What it does is it reduces the hepatic steatosis and also it decreases the inflammation, decreases the TGF-beta signaling, so it decreases the fibrosis. This is the MASTRO-NASH trial. It's a randomized placebo-controlled trial, 3 arms. I'll just cut to the chase. I'll go to the. This is the efficacy data based upon the intention to treat analysis. Almost 30% of patients resolved inflammation without any worsening of fibrosis. 25% of patients reversed stage 1 fibrosis. Based upon this data, this got approved last year. And the diarrhea and nausea seem to be the major side effects. But most of my patients will go through the first 2 to 3 weeks, they'll get diarrhea and nausea. If you prolong it next to 4 weeks, they all disappear. Only one patient I had to stop this medication because of persistent diarrhea. Most of the time, these side effects are tolerable. Now, this is the algorithm we recommend. Whom would you treat? If anyone has a transient elastography about 10 kilopascal, the MRE about 3.3, L score about 9.2, but make sure they don't have any evidence of portal hypertension, such as platelet count less than 140 or any evidence of ascites or cirrhotic, because this drug is not approved for cirrhosis. Oh, this is the evolving therapy. As you all know, semaglutide got approved a month ago for MASH patients with stage 2 to 3 fibrosis. The other GLP-1 agonist, the combination of GLP-1 agonist and GIP, tirzepatide, as well as GLP-1 agonist and glucagon receptor agonist, they are all going through phase 2 and phase 3 trial. This trial, the data is encouraging. There are some FGF21 agonist. FGF21 agonist, the efruxifermin, you can give once a month shot. When PPAR agonists like lanfibranor, they are all undergoing phase 2, phase 3 trial. So stay tuned for the more data to emerge. Now let me, how do I forecast the evolving treatment? This is the third step. Once we come up with an anti-steatotic, we have to come up with an anti-fibrotic. You have to combine them, especially in a cirrhotic patient, well-compensated cirrhotic patient coming in front of you. We should combine both anti-steatotic as well as anti-fibrotic therapy. We still don't have a good anti-fibrotic therapy for cirrhotic patients yet. So let me conclude. MASH and its complications are growing. NIT, non-invasive test algorithm, can be used to risk stratify and also monitor the patient on treatment. Management of risk associated with MASH requires multidisciplinary team such as physiotherapist, dietitian, bariatric endoscopist, and so on and so forth. Resmetirom and semaglutide are the only 2 approved treatment for MASH, especially in patients with stage 2 and 3 fibrosis. And I'll stop here and entertain any questions. Thank you all for listening to me. Yes? Okay, sure. So the question is the combination therapy GLP-1 agonist and THR beta agonist, correct? Yes. Answer is in the study in the MASTRO-NASH trial, 50.
So we all know that about 1% of our population, so let's say the US population is about 300 million. So 1% of the population in this country has mitral valve prolapse. The mitral valve prolapse we all know about. Most of us didn't even think about it. It happens. Patients go on continuing with their life, nothing happens. But a fraction of it, about 1/3 of these mitral valve prolapse patients get into malignant cardiac arrhythmias. We do not know why. And more studies, I think in the last 5 years, every year about 50 studies has been published in the last 5 years. It's about 250 papers came out on this topic, the mitral annular disjunction that I talked about. It's a representation of how degenerative the valve annulus can become. So it's very hypermobile leaflets and the annulus that results in abnormal dynamics of the basal left ventricular wall. As a result, you're going to get fibrosis. So we all know fibrosis anywhere in the body is a problem, but fibrosis in the heart is more of a problem because it's going to give us the ventricular arrhythmias, such as paroxysmal ventricular contractions or PVCs, ventricular tachycardia, or the worst of all is ventricular fibrillation. So if you hear about this mitral valve prolapse, think about asking a question: is it possible that what you're dealing with is more than mitral valve prolapse? Most of the times, as I said, 2/3 of them, nothing happens to them. 1/3 of them will develop unexplainable cardiac arrhythmias. So they have no ischemic heart disease, they have no non-ischemic cardiomyopathy, but they have something else, unexplainable cardiac arrhythmias. That's what we should think about as mitral annular disjunction. So the surgeons can go and fix the annulus. Not only the valve leaflet needs to be fixed, the annulus needs to be stitched together. So that's the reason why we need to know about this. Okay? So that's mitral annular disjunction. So that's number one. So number two, I'm going to talk to you about this myth that is going to be about interstitial lung disease, fibrotic interstitial lung disease in Indian population. Right? So there's a registry it exists in India, but there are few papers are coming out of India. One of them is maybe 3 years ago. That paper is a survey data. So they surveyed a group of pulmonologists that attend the conferences, and they asked about fill up the survey about interstitial lung disease. So the data is a sample data, so that's fine, but that is not somewhere. So that data is the physicians, the pulmonary physicians, about 90% of those folks who fill the surveys are pulmonologists. And those pulmonologists from 22 states in India, so it's a wide representation, it's a good sample. And they all talked about their experience of interstitial lung disease. And the number one cause of fibrotic interstitial lung disease is, can you guys guess? I think I'm hearing some fibrosis. Pollution, right? Because that's etiology. So the diagnosis that we want to give is chronic hypersensitivity pneumonitis. So it is organic, metallic, dust exposure related problem. So, thank you. Now I'm official. So it's an organic and metallic dust exposure related problem. So most of the time it's pollution and the air conditioners and having pet birds in their home, and obviously unhealthy environments. So of course the basement issue doesn't exist in India, unlike in US. So the fungal mold related problems doesn't exist that much, but it's still there because of poor hygienes and things, obviously smoking. So inhalational problems, so organic metallic dust exposure problem results in chronic hypersensitivity pneumonitis. So that's something that we should think about. Those are two things that, the chronic fibrotic interstitial lung disease is something that we really have to think about. So we all live here, but when someone goes into intensive care, think about, could it be anything more than pneumonia? So that's a part that we should think about as physicians. All right, so I'm going to see if I can show you the slides, but of course I'm not going to take a lot of your time. And let's see, function F5. Yep, and it's here, okay. All right, thank you. So these are the two things that I talked to you about. and the mitral annular disjunction. So this is normal, right? So we have this. Let's see. We have the pointer. Yeah. So here is this is the cardiac MRI, but it doesn't matter. It's a heart. So this is the left atrium, this is the left ventricle, that's the mitral valve, that's normal. So see how nicely it is sitting on top of this myocardium. So that's normal. But this is abnormal. And see how this is bulging, prolapsing, and it's detached from the top of this myocardium. It's about one centimeter away from the top of this myocardium. So this is mitral valve prolapse that continue to degenerate into mitral annular disjunction. So most of the cardiologists don't know about this, and this is increasingly being recognized. So this is the mitral annular disjunction that I'm talking about. It's a flailing annulus. It's a very degenerated, bulging, ballooning up annulus. So why do we need to know about that? Is because, as I said before, scars plus this entity results in this. So there's a strong association and correlation in patients who have ventricular arrhythmias. So abnormal enhancement in the myocardial tissue is bad. That indicates fibrosis. That results in cardiac arrhythmias. So if you ask yourself, mitral valve regurgitation, if you see it, anything more than moderate to severe, think about, am I dealing with mitral valve prolapse? If I see this, 1/3 of them will have this problem, and that is this. So mitral annular disjunction. That's number one. Number two is what I talked to you about this. So that's a group of physicians, interstitial lung disease interested physicians from 24 states attending interstitial lung disease conference. So there's a selection bias here, but nevertheless, vast majority of them are physicians who are expert in taking care of lung. They are focused practicing in half of them on private practice, 1/3 in the academic centers. They are not babies. So they are at least a decade-old physicians. And as I said, chronic hypersensitive pneumonitis that we always think it is a Western problem, it is not. It is also a worldwide problem. And everybody pretty much ranked that vast number high as chronic hypersensitive pneumonitis. On pictures, this is how it looks like. In the upper lungs, a lot of fibrosis, ground glass, distorted airways, fibrotic lung, that's how it's going to look like. And majority of the time, so about 40% of the time, respondents said, I do not know what the problem is. So I do not know what the problem is. So that's what they said. So that doesn't mean that it's not there. So if you think about it, so chronic hypersensitive pneumonitis, so birds, air conditioners, air coolers, moles, rural residents. And obviously, these are all the common culprits why somebody will have, so highest associations, highest correlation. So these are the two items, as I told you before, mitral annular disjunction and interstitial lung disease is not a myth in India. It is there. Once again, I thank you very much for your patience and understanding and listening to me.